Welcome to Clinical Capsules from TRC Healthcare, your trusted source for practical, evidence based updates. On this episode, Assistant Editor and Clinical Pharmacist Gina Corley walks us through advanced therapies used to help manage Crohn disease. She discusses biologics and JAK inhibitors, outlines their place in therapy, and also highlights the role of immunomodulators and steroids in an excerpt from our popular Pharmacy Essential Updates webinar series. This podcast offers continuing education credit for pharmacists and pharmacy technicians. Please log into your pharmacist letter or pharmacy technician's letter account and look for the title of this podcast in the list of available CE courses. None of the speakers have anything to disclose. Catch new episodes of Clinical Capsules every second and fourth Tuesday, bringing concise, actionable insights from TRC experts straight to your ears. Let's dive in.
So now we're going to dive into some of the advanced therapies that are used to treat Crohn's disease. And just like our article says, you'll see more upfront use of advanced therapies in moderate to severe Crohn's disease due to updated guidelines. But what do we mean by advanced therapies? What types of drugs are these? We'll go into all that in just a bit, but first, let's remind ourselves what Crohn's disease is. So Crohn's disease is a type of inflammatory bowel disease that can cause things like stomach upset, severe diarrhea, bloody stools, fatigue, and weight loss. And while Crohn's disease can affect different areas of the digestive system, it most commonly affects the area that's towards the end of the small intestine and the beginning of the large intestine. Inflammation from Crohn's disease can also spread into deeper layers of the bowel. And as you can imagine, this can be very painful and debilitating. And the way we treat Crohn's disease has evolved over the years. In the past, we used what was known as a step-up approach. Patients would start with oral corticosteroids, such as prednisone, to induce remission. Then they would usually transition to an immunomodulator, such as azathioprine or methotrexate, for maintenance therapy. And these immunomodulators would work to help enhance the body's immune response against Crohn's disease. Now, if this wasn't enough, patients could transition to injectable biologics, which are more advanced therapies to help manage their symptoms better. Two of the most common biologics are infliximab and adalimumab, and we'll go into the details of these a little more later. Now, let's fast forward a bit. More recent guidelines recommend starting biologics sooner rather than doing a step-up approach. Keep in mind, immunomodulators such as azathioprine or methotrexate could still be added on to biologics, which helps to reduce the risk of forming anti-drug antibodies, and therefore increases the chance that the patient will respond to the biologic. And then the most recent set of guidelines created a really streamlined approach and recommended using advanced therapies up front. And of course, we just touched on what advanced therapies were, but let's dig a little deeper. So like we said, the most common advanced therapies used in Crohn's disease are biologics. So let's talk about what a biologic actually is. Biologics are medications that come from living organisms. Scientists will take proteins or genetic materials from living cells and reproduce, clone, or mutate them somehow to get the desired drug that they need. This is why biologics are often used to treat difficult diseases, such as autoimmune diseases, that drugs made in a more traditional way cannot treat. And as you can imagine, making drugs this way can get a little pricey, which is why many biologics cost tens of thousands of dollars, often require prior authorizations, and are usually dispensed from specialty pharmacies. Now, you'll notice that all the biologics I mentioned for Crohn's disease all end in mab. And this is because they are a specific class of biologics called monoclonal antibodies. Monoclonal antibodies are made up of many copies of a single antibody, which is a protective protein made by your immune system. This allows these drugs to target and destroy certain disease cells in the body. So let's get into some of the different monoclonal antibodies used to treat Crohn's disease. In a patient who has never taken a biologic before, guidelines say to start with a high-efficacy med. So for example, patients typically start with infliximab or adalimumab. But for patients who have tried and failed biologics, guidelines suggest that a high or intermediate efficacy med can be used. So that means if a patient tries infliximab and doesn't respond, we can switch them to a high or intermediate efficacy med, usually in a different class. So while most of the drugs end in mab, there's one that does not. And this is Upadacitinib. This med is a Janus kinase or a JAK inhibitor. So it is not a monoclonal antibody, nor is it a biologic, but it's still considered an advanced therapy for Crohn's disease. So now let's take a deeper look into all of these meds and their classes. All right, starting off with the TNF-alpha inhibitors. These meds include infliximab or Remicade, adalimumab or Humira, and certolizumab or Cimzia. Infliximab and adalimumab are usually first line for Crohn's disease. Both are considered high-efficacy meds. And like I previously mentioned, you may see one of these meds combined with an immunomodulator, such as azathioprine, to help improve patient response. And then sometimes, patients will also start on a steroid to help manage Crohn's disease symptoms while they wait for biologics to kick in. Conversely, certolizumab is a lower efficacy med, so we aren't likely to see this one used as often. And then I wanted to touch on the dosing for adalimumab and infliximab, since these are common meds for Crohn's disease. Adalimumab is given subcutaneously, either as a single 160 milligram dose on day 1 or in 2 divided 80 milligram doses on days 1 and 2. After that, patients will get 80 milligrams on week 2 and then 40 milligrams every other week after that. The first injection must be given by a healthcare provider, but after that, patients are able to inject themselves if they feel comfortable. And then on the other hand, patients who get infliximab must start with IV therapy. So they'll get a 5 mg per kg induction dose at weeks 0, 2, and 6. And then for maintenance dosing, they can either do 5 to 10 mg per kg IV every 8 weeks or 120 milligrams subcutaneously every 2 weeks. The IV infusion must be administered by a healthcare provider in a clinic, but patients opting for the subcutaneous injection can administer the dose themselves. Next, we'll talk about the non-selective anti-interleukin med, ustekinumab or Stelara. This med is considered higher efficacy in biologic-naive patients, but is intermediate efficacy if patients have prior biologic exposure. It's older than the more selective anti-interleukin meds that we'll talk about next, so its effects tend to be more moderate. We usually consider this med for patients who don't respond to TNF-alpha inhibitors. And similarly to the TNF-alpha inhibitors, it can also be used with or without immunomodulators. Induction dosing for ustekinumab is weight-based and given IV. Patients 55 kilograms or under will get 260 milligrams IV. And then patients 56 to 85 kilograms will get 390 milligrams IV. And lastly, patients over 85 kilograms will get 520 milligrams IV. Then maintenance dosing is the same 90 milligrams every 8 weeks for all patients, but this time it's given subcutaneously. Moving right along, we have the selective interleukin-23 antagonists, guselkumab or Tremfya, mirikizumab or Omvo, and risankizumab or Skyrizi. All 3 of these meds are newer and considered higher efficacy in biologic-naive patients. Guselkumab and risankizumab are also high efficacy if patients failed prior biologics, but mirikizumab's efficacy is more intermediate. And then, like the other meds, these can either be given IV or subcutaneously, depending on the drug. So, for example, guselkumab can be given IV or subcutaneously for maintenance dosing, but mirikizumab and risankizumab are both given IV. And then, even though all maintenance doses are given subcutaneously, dosing regimens can vary. So, for example, risankizumab can be dosed at 180 milligrams or 360 milligrams, depending on disease severity. Next, we have vedolizumab or Entyvio, which is an anti-integrin med. This one is high efficacy in biologic naive patients. But if patients failed biologics, we likely won't see it used, since it's considered low efficacy in this instance. And then for dosing, patients take a 300 milligram IV induction dose at weeks 0, 2, and 6, and then have a couple different options for maintenance doses depending on their disease state. Lastly, we have Upadacitinib or Rinvoq. Like I mentioned before, this is the only advanced therapy med that is not a biologic or monoclonal antibody. Instead, it is a Janus kinase or a JAK inhibitor and is the first oral med that is indicated for moderate to severe Crohn disease. It's reserved for patients who have failed prior biologic therapy and therefore should not be initiated first line. It also should not be combined with biologics or immunomodulators because it can have added immunosuppressant effects and make patients more susceptible to severe infections or cancers, as well as thrombosis or blood clots and cardiovascular events. All right, so now let's cover some risks and side effects we want to watch out for with all biologics. Biologics can suppress the immune system, and this can make patients more susceptible to infections like we just mentioned with Upadacitinib. To help reduce this risk, we want to make sure most vaccines are up to date. However, we want to avoid live vaccines in these patients since this can lead to a vaccine-induced infection or illness. And then along those same lines, patients on biologics are also at increased risk of developing complications from surgery, such as delayed wound healing or post-op infections, along with certain cancers such as lymphoma or non-melanoma skin cancer. And then, since these are injectables, patients may also have infusion-related reactions, such as redness, swelling, or injection site pain, and may need to premedicate with antihistamines such as diphenhydramine or steroids like hydrocortisone. And then lastly, I just wanted to touch on a few practice pearls to go over if a patient drops off a prescription for an advanced therapy med. Like I mentioned, these meds can have very complicated dosing regimens, so we want to be extra careful when inputting prescriptions into the computer system. Make sure to double check the dose, route, and frequency, since these things can all vary with the different therapies. Keep in mind, you'll likely be transferring these prescriptions to specialty pharmacies, but we still want to update patient profiles to include these meds, so the pharmacist can screen for drug interactions or ask about vaccines. And then if you do happen to stock any of these meds in your pharmacy, make sure you check the storage requirements. Most of the injectable biologics will be kept in the fridge, but keep oral Upadacitinib stored at room temperature. All right, so I know that was a lot of information we went over today, and these meds are not always easy to keep straight. But we have this really nice chart on our website, Biologics and JAK inhibitors for moderate to severe Crohn disease, that breaks down each class of meds. It gives info on dosing, side effects, and place in therapy, along with things to watch out for when patients are on these advanced therapies.
Thanks for listening. We hope today's episode gave you practical insights you can use right away. Now that you've listened, pharmacists and pharmacy technicians can receive CE credit. Just log into your pharmacist letter or pharmacy technician's letter account and look for the title of this podcast in the list of available CE courses. We've linked the resources we mentioned and more on today's topic right in the show notes. Those links will take you straight to our websites, where you'll find even more concise, evidence-based charts, articles, and tools. If you're not yet a subscriber, now's the time. Sign up today to stay ahead with trusted, unbiased insights and continuing education. Listeners save 10% on a new or upgraded subscription. Just use code CC1026 at checkout. Have a question or a topic suggestion? Reach out using the Send Us Fan Mail link in the show notes, or email contact us at trchealthcare.com. Your perspective matters. Share your thoughts anytime to help shape future episodes. Thanks for listening. Stay sharp, stay current, and join us next time on Clinical Capsules.